Thank you for joining us for tonight's educational webinar on hip and knee arthritis. Tonight's speaker is Dr. Mark Kolich, OrthoNeuro orthopedic surgeon. Dr. Kolich is fellowship-trained orthopedic surgeon specializing in outpatient total joint replacement, minimally invasive anterior approach, hip arthroplasty, less invasive total knee replacement, and complicated hip and knee revisions. Please type questions in the Q&A box below, and Dr. Kolich will answer questions following his presentation. Dr. Kolich?
Thank you, Heather. Appreciate it. So there's a number of things that we're going to discuss here today. So welcome and introductions, as well as go through, a number of different questions that generally patients will ask, as well as what is arthritis? What are the symptoms, the prevalence, the diagnosis? Talk about different treatment options, what that looks like in both the hip and the knee in terms of anatomy when arthritis does develop. And then when patients are considering surgery, when you should consider surgery, the joint replacement journey, and then I'll answer questions at the end, okay? So a lot of times I ask patients, have you experienced any of these problems within the following problems within the last week? Any issues getting out of bed? Any issues going up and down stairs? Housework, gardening, getting in and out of a car? A lot of patients to talk about having discomfort, in particular with the knee going from sitting to standing. Prolonged sitting, especially with hip arthritis, can also cause patients some significant pain and discomfort. One of the most common complaints that I'll hear from patients in the office is that they have difficulty with any kneeling or squatting when they're kneeling directly down onto their knee or going downstairs, in particular on a bent knee. Patients can sometimes have difficulty fully bending or straightening their knee if they have any swelling on their knee, or as they're developing arthritis. Patients will have that complaint often. Difficulty pivoting, tying shoes, crossing legs, activities like shopping, and everyday activities, that you're moving and living life sometimes can become more difficult. So the anatomy of the knee. So I want to give you a little background behind the knee, what that looks like, what I'm talking about, what I'm referring to, as well as the hip, and I'll go through that in the next slide. So the anatomy of the knee. This is the largest and strongest joint in the body. It's made of the lower end of which is the thigh bone or the femur. And then there's also the upper end of the lower extremity, which we call the tibia, which is often referred to as the shin bone, that makes up the predominant weight-bearing portion of the knee. I talk to patients a lot about, when I'm looking at their x-rays or when I'm referring to them their knee, that the predominant weight-bearing portion is on the inner and outer aspect of the knee. On the back side of the kneecap is that third compartment that often can give patients trouble as well, which we call the kneecap, or the patella is the proper term for that. There is a shock absorber that sits between these bones and sometimes can become an issue that we call the meniscus. That meniscus looks like the letter C, and it sits, and we have two of them. We have one on the inside of the knee and one on the outside of the knee. Sometimes you can have issues as you develop arthritis in the knee where that meniscus can become torn. Anatomy of the hip. So when we look at the hip is a ball and socket. There's a ball that we call the femoral head, as well as the rounded socket that we call the acetabulum that ball fits into the pelvis. The cartilage that's on the end of that hip bone, on the end of that ball, okay, oftentimes as you develop arthritis, you lose that cushion on the end of that ball, okay, and once that becomes roughened or cracked, starts to have these little cracks in there, or potentially these little, what I call potholes in the joint surface, that ball no longer rotates as easily. It should be nice and smooth and shiny, like the cartilage on the end of a chicken bone, okay? What is joint arthritis? So that's why we're here today. So arthritis is the inflammation of your joint that develops over time. So arthritis can make it hard to complete everyday activities. Although there's no cure or no way of regrowing cartilage, there are treatment options to help patients alleviate some of the pain that comes along with that, and especially some of the flare-ups that can happen, and help keep patients active. So I put two pictures here. So basically, when we're looking or talking about knee arthritis, or when we're looking at the hip joint, okay, both of them have this smooth, shiny cartilage on the end, okay, of that inside that joint. It should look like the picture on the left. When we're looking at the knee, they colored the cartilage blue. But when you have the loss of cartilage, this does happen in stages, so it's not all or none. So sometimes it's none by the time I see patients, but generally patients go through these stages to where they lose more cartilage, and ultimately they have this loss of cartilage, where you're seeing those potholes on the side of that, on that image on the right, and you're starting to see more bone lay down to prevent motion. And you're starting to see those little growths, it looks like, on the side of that knee there that we call bone spurs or osteophytes. Looking at the hip joint, it's a similar appearance, so that the ball and socket is a much smaller joint. So the top of the ball generally is where we develop arthritis. As we step down, that ball generally moves north, or the pressure is applied at the top of that ball. So a lot of patients that do have arthritis in their hip do have issues to where they're getting thinning of that cartilage and wear of that cartilage on the end of that hip bone. And we also will see that on the socket side at the acetabulum. So like I just mentioned, so what is joint arthritis? So osteoarthritis, this is the most common form of arthritis, and it's a degenerative wear and tear type pattern that we see. This is when that shock absorber gradually wears over time. And like I said, patients, sometimes it's not all or none in terms of wear and tear. Patients can go through these phases, and oftentimes they end up in my office in this mild to moderate and sometimes severe, okay, to where they gradually do lose some of that cartilage. And you see this chart here that we have grade 1, 2, 3, and 4, okay, and that's what results in that bone rubbing and pain, okay. So the symptoms of joint arthritis. So there's a number of different symptoms, and they're not just physical. So there's physical, psychological, and there's contributing factors that cause some of these symptoms as well, and I'll touch on those. So the physical symptoms of joint arthritis is patients will feel aching, pain. They'll feel increased temperature sometimes, some of that limited mobility where they're not able to move that joint as much as they were before, okay? That sometimes they'll describe as some stiffness, okay? Patients can have difficulty walking or climbing stairs as a result, and oftentimes getting up out of a chair or getting in and out of the bathtub sometimes can be difficult. And typically this is a later symptom, but patients can have some disruption of their sleep as that arthritis continues to advance. And generally when sleep starts to become disruptive, oftentimes I do see patients in the office as this is very difficult for them to move on with their life, as they're not able to achieve any rest. Oftentimes, especially in the knee, not as much in the hip, patients will talk about a grating or grinding or kind of this crunchy feeling that sometimes that they'll appreciate in their knee as their knee is put through range of motion. And oftentimes, patients, when I see them, sometimes if this has been going on for a long time and it's affecting their life in terms of it's affecting their work, it's they're not able to do the things that they want to do or go places or do the things that they used to, there can definitely be some psychological effects where patients can have issues with depression. And I often see patients in the office that are fearful of surgery because they're fearful of the unknown. So I'm happy to talk to patients and talk them through them. I often tell folks too that if I've treated a patient and someone sends someone to me, those are some of my favorite patients to see in the office because they're less fearful of surgery and they're excited to hopefully move on with having their hip or their knee addressed. Because a lot of times patients aren't sure who to go to or who to talk to or who to trust. And I'm always happy to answer questions for patients and walk them through that process. Okay. Contributing factors. There's a number of contributing factors for joint arthritis. It can be age, weight, your activity level, especially if it's high impact activity. Some of the additional stress on the knee joint or the hip joint, definitely accelerates some of that wear. And sometimes patients can have repeated injuries to their hip or their knee or a remote injury from before. And over time, they develop some post-traumatic wear and tear inside their hip or knee. Okay. You're not alone. So there's a lot of patients that are out there that have hip and knee arthritis. So close to 3 in 10 adults, 18 and older, report having problems with their joints. 21%. It's a big number. 21% of patients have arthritis. So 17% suffer from pain, stiffness, loss of flexibility in their joints. 54 million adults have doctor-diagnosed arthritis. So arthritis is the most common cause of work disability in the United States. So, and these are big numbers. There's a lot of patients that, and this continues to grow. 700,000 knee replacements, 325,000 hip replacements are performed yearly in the United States. So there's a lot of folks that are out there that are having issues with their hip or their knee. So how do we diagnose a knee problem? And I'll go through a hip problem as well. So, it's a combination of things, right? So generally patients I'll see them in the office. I'll listen to their history. I like to do a physical exam. So I physically put my hand on their knee or assess their hip. Okay. I compare that and look at their x-rays or their advanced imaging. Sometimes patients come in with an MRI already or a CT, a bone scan. Some patients have some additional lab work if we're thinking about other things that may be going on that may be causing some hip or some knee pain that may not be arthritis. So, I also evaluate lab tests. Okay. In reviewing x-rays, when we look at x-rays, I often like to print out x-rays so patients can look at them and I can talk them through the things that I'm thinking about and what I'm seeing and where the differences are, especially, as I get x-rays of one joint in the other joint. Say you have a left knee problem, I also have images of your right knee so I can compare the two. Okay, so when we look at this x-ray, the normal x-ray of a knee joint is on this left side. So what we're seeing is that the two bones are lined up very well. We're seeing that there's this dark space between the inner and outer aspect of the knee. That dark space, okay, represents the cartilage that's between the thigh bone and that shin bone, okay? That space should be equal and it should be a very clear, well-defined picture, which is what we're seeing on this normal knee joint, okay? When patients develop arthritis, as we slide over to the image on the other side, what we're seeing is that dark space has disappeared. That dark space is that cartilage, right? So there's no mineral within our cartilage, and when we get an x-ray, it should show up as a blank space or that void. When that void disappears, like the arthritic knee joint that we see on the right side, we see that those two bones are now touching. And we also see there's that bright white appearance, which is hardening of the bone that develops with arthritis. And then we're also seeing off of the corner of that knee some bone spurs or osteophytes, we like to call them, that are developing as a result, like the images like we reviewed earlier, okay? What you're also seeing is that shin bone is no longer in a straight position. You're seeing it in a slightly angled position, okay? If patients develop arthritis on the other side, sometimes the knee joint will swing in the other direction, okay? So the x-rays just help us understand what's going on and help interpret that with patients so they understand what their knee joint looks like, where they currently are, okay? So this would be more of the no arthritis and bone-on-bone arthritis, the grade 4 that we talked about. This is not really in that mild to moderate. This is more in that severe realm, okay? When we review x-rays of the hip, okay, so this one is a nice image because we're able to see the right side as well as the left side, okay, which, the right side is actually the left side of the screen, okay? But when we look at the hip joint, there should be a space at the top of that ball, which represents that smooth, shiny articular cartilage on the end of that hip bone that creates that space. The most common wear pattern that I see in hip arthritis is that patients will lose that cushion on the top of that ball, and that top of that ball comes in contact with the top of the socket or the acetabulum, like we talked about. When patients start to lose that space, okay, you start to see the same things. And in this patient in particular, you start to see that the ball is losing its sphericity and the ball is starting to appear flattened at the very top, okay, in addition to that bright white hardened bone and some bone spurs that are starting to develop. The other thing that's also starting to happen is as this patient is developing arthritis, this hip joint is no longer sitting well centered within the socket and starting to slide north and a little bit lateral, meaning it is starting to move up and out. So what are our treatment options? So discussing the number of treatment options, I like to go through all these with my patients. So I always tell them, just because you're seeing a surgeon doesn't mean that, I'm only going to talk to you about surgery, right? So I like to talk to patients about all of their options, the non-surgical with surgical options, if it's indicated, okay? So the non-surgical treatment options are, activity modification, right? So low impact, exercise to where we're doing things slightly different and potentially working out slightly different because sometimes our workout contributes to some of the issues that patients may be having. So all the low impact aerobic exercise is fantastic for our joints, our biking or swimming or yoga or Pilates. All of those things, are healthy that help keep our joints healthy. Okay. The only way that the cartilage receives nutrition is through diffusion, what we call diffusion, meaning that the joint fluid is actually passing over the cartilage and bringing it nutrients. I do like to talk to patients potentially about dietary supplements if there's any issues, if you're not getting that through your everyday diet. Potentially weight loss. There's some really good studies that are out there that show that even a 10-pound weight change can make a substantial difference in how our joints feel, okay, and how patients feel, okay. Sometimes physical therapy is appropriate. As patients do develop more of an end-stage arthritis, sometimes I talk to them, yes, it may not change the fact that you do have arthritis, but it can help achieve potentially some increased flexibility, decrease some of the symptoms. Sometimes if we could increase some strength, it can add stability to that hip or knee joint, okay? In some cases, bracing may be an option, and we have a number of different braces, and I'm very specific on what I'm writing for patients depending on their arthritic wear profile, as well as their issues that they may be having, potentially instability, which patients with instability may be a better candidate for bracing, okay? Prescription medications definitely have a role. I talk to patients about anti-inflammatories, and it's one of those things that I don't want patients to be on anti-inflammatories for a prolonged period of time. There's definitely springs and strains and other things that are very appropriate in treating inflammation. Ultimately, fixing the problem does help patients, and it's not as hard on the lining of your GI tract or your stomach, and it's not going to be as hard on potentially your kidneys or your liver being on medications in a prolonged fashion. So there's a role, for medications, but I do have, a period of time that I like to have patients on them and not forever, okay? Assistive devices may be necessary for patients, especially if there's a risk for falls. I do talk to patients about a number of different joint injections, and I'll talk to you about the options that are there. And then I do talk to patients about surgical options when appropriate. When they check all those boxes and patients get to the point to where they've attempted all of those conservative treatment options and putting together their physical exam with their imaging in addition to that history and what they've attempted, and when they get to the point to where it's affecting their quality of life despite the conservative treatments that are offering and that were offered or they've completed, I do have the discussion, does surgery make sense for a patient, whether it may be arthroscopy, which is putting a small camera into the joint and trying to clean things up, or replacing the joint altogether to where, and I'll get into what that looks like, okay? Joint injection. So, I generally talk to patients about, there are 3 different options that are out there. There's steroids that are out there that work very quickly, work very well, and knock patients' inflammation down rapidly. There's a role for that, and I do evaluate which patients may be candidates for that. I do also hyaluronic acid injections for patients to where we're administering a lubricant to the generally the knee joint. And when we do that, it's proposed that your knee joint will make more natural lubricant, potentially over a 6-month period. And they're generally indicated for patients that have mild to moderate arthritis. Patients that fall into that severe realm, generally, they may not respond as well. Some patients that do have some more of their arthritis behind the patella or back behind the kneecap, rather than the weight-bearing surfaces that we described earlier in the anatomy section, I do find that some of those patients do respond a little bit better, okay? I'm also doing some regenerative medicine with platelet-rich plasma. So we actually have that in a number of our offices now, and it's been a great resource for patients to, go down that avenue. And I've had some very happy patients receiving platelet-rich plasma and some of this regenerative medicine that, they may not want to, entertain a steroid or a hyaluronic acid type of injection. I do generally tell patients that if you do want to go down the path of a platelet-rich plasma, they do work well, okay, but generally the insurance isn't covering some of these injections. So we have a number of different options that are tiered to make them more approachable for patients. And I tell patients that, it's something to where the kit to do this is the most expensive cost for that. So the charge for that is the overwhelming majority is just to pay for that kit, so we can give patients access to, this option if that's something that they're interested in pursuing, okay? But platelet-rich plasma is where we're taking patients' own blood. We draw that in the office, and then we put it through a centrifuge. So when we spin that blood sample, what we're able to do is actually concentrate the growth and healing factors that are naturally within our bloodstream, okay? So when we take that concentrated platelet-rich plasma and we put that back into that knee joint, I tell patients that those platelets open up. They help promote healing in that area. And what it'll do is it recruits to the rest of that body, or sends a signal from the rest of the body to go to that area to help it heal. So it has this kind of snowball effect where it may not work as quickly up front as the steroid would. Okay, but patients that do these, I've seen less swelling, less discomfort, but again, it has to be appropriate. And I look at each patient on an individual basis. And if patients are in that end stage, realm, it's less likely that it's going to work for them. This is a difficult thing to study because every patient is completely different. So their sample is going to be completely different. So the concentration of those platelet-rich plasma, those leukocytes that are within and the platelets that are within that sample, are going to be different from one patient to another. But I'd be happy to have a discussion with patients on whether or not they'd be a candidate. And there are other locations that we do these. Our upper extremity folks do them in the elbow, often for tennis elbow. This works very well for patients that have hip bursitis, and I do a number of these injections for patients that have had persistent bursitis on the side of their hip. Okay. So when should you consider knee surgery or hip surgery, right? So, I have this discussion, right? And like I touched on earlier, I talk to patients oftentimes of, I'm listening to you. I'm listening to that history. I'm evaluating that hip or that knee. And I'm also incorporating those images, that we talked about earlier. And I'm trying to put everything together. Okay. And when I'm putting everything together, I don't make the decision for the patient, but, as I go through things with patients, oftentimes it becomes very clear, when they're ready. And most patients will know, right? To where, they've got bone-on-bone arthritis. They've failed all their conservative treatments. They've got limited painful range of motion in their hip or their knee, or they may not be able to sleep anymore at night. They may not be able to complete, tasks at work, or things where they're not going places or going to the beach because uneven surfaces are uncomfortable for them, okay? I have a number of patients that after putting all those things together, a lot of times they're able to make that decision for themselves. And I tell patients I wouldn't offer them surgery if they weren't ready and they didn't check all of those boxes. But, oftentimes those are all the same things that patients will say, when they're at that point to where they're ready to move forward with a hip or knee replacement. So same thing, same thing with hip. It's just a little bit different. It's very hard to avoid some of the discomfort in the hip. Sometimes it's easier to hide some knee arthritis issues as you're able to kind of swing your knee around. But the hip, when you sit, you're bending to 90 degrees. When you're sleeping or standing, you're straight, right? So when you do that, those extremes of motion are unavoidable, right? So patients sitting and sleeping and walking and getting up out of a chair elicits a lot of pain in the hip. And, oftentimes it's something that, that small ball that's in that socket, once it starts to wear, it can wear pretty quickly. And I do see that, patients that have hip arthritis generally is on a shorter time frame to when, it may present to where ultimately they may need a hip replacement. So surgical treatment options. So there's a number of different treatments for the knee as well as the hip, and I'll go through some of the things that I do around the knee. So patients that don't have as much of an issue with the cartilage, and they have some advanced imaging in the knee that may show a meniscus tear, right? So if they've got an issue with the shock absorber or that cartilage that sits between those two bones, and they don't have an issue with their cartilage, sometimes those patients are good candidates for knee arthroscopy, where we put a small camera and a little trimmer or shaver inside that knee, and we round out that meniscus so it doesn't catch like a hangnail anymore. Partial knee replacement, patients that do have issues with their cartilage, but they only have issues with one of those three compartments that we talked about in an anatomy section. Patients that have issues on the inner aspect of their knee, okay, or potentially just behind their kneecap or just on the outer aspect of their knee, they may be an ideal candidate for a partial knee replacement. Generally, they do get some additional x-rays or sometimes some advanced imaging just to ensure that there's no issues with the other compartments. But the patients that meet the criteria for a partial knee replacement, I do talk to them about that as a potential option moving forward and if that makes sense for them. A total knee replacement is something where we're replacing all three compartments to where the inner, the outer, potentially up underneath the kneecap. If two of the three compartments do have arthritis, generally I'm talking to patients about a total knee replacement. instead of a partial knee replacement or knee arthroscopy, okay? And then, generally, speaking here too, 90% of patients are now undergoing most of these surgeries on an outpatient basis, and I am evaluating each one of those patients. Are they an appropriate candidate? Does this make sense? What resources do they have, and folks to help them at home? Okay. Surgical treatment options. So when we look at the hip, arthroscopy in the hip is an option for patients. I don't see it as frequently as I do around the knee. But sometimes patients can have issues with the tear of the labrum, which is around the rim of the socket. And some of those folks may meet the criteria for a less invasive hip arthroscopy to either repair it or clean up that labrum if it's torn and the cartilage is healthy. The overwhelming majority of patients, as they develop some arthritis and loss of cartilage on the end of that hip bone, they do wear into that labrum. So most folks that do have a labral tear also do have arthritis. So most of them, I'm discussing with them a hip replacement to ultimately, get patients back to doing the things that they were doing through a less invasive approach. Okay, so joint replacement is definitely not appropriate for all patients, but this has come a long way, and it's been one of the most successful things that we've done in orthopedics. Is the hip replacement procedure, and we've come so far, along to where these folks are going home on an outpatient basis with a minimally invasive incision, at least in my hands, through an anterior approach, okay, which I don't touch any of that muscle. I literally push the muscle out of the way, so patients' pain scores are substantially less, and they're getting up and moving around much quicker, okay. So what are the goals of a new joint? So, ideally, when we have a joint replacement, this should reduce pain, right? So that's why we're doing it, okay? This should improve the quality of life. And you'll hear me continue to say that. And if you see me in the office, I really focus on patients and where their quality of life falls, okay? Because I think that's a much, easier measure, a much better measure to look at in terms of making a judgment call on which direction we should go with operative versus non-operative treatment options, okay? So this should regain your strength and mobility. A lot of folks don't realize how much strength they've lost leading up to potentially their joint replacement. And once that joint is replaced and they no longer have that arthritis stopping their mobility, they realize how much the muscles and tendons around the hip or the knee have become weakened or tightened, okay, leading up to that, or contracted. So physical therapy is really important, afterwards, to really regain that strength, regain that mobility, help patients stretch back out, and ultimately get back to living their life. And I tell patients that, for me, what I'm looking for is the forgotten joint, to where you forget about, you ever had anything done to that joint, okay? So joint replacement success. So, nowadays we've come a long way with technology, right? So there's been some significant advances in terms of our technology, our instrumentation, the actual hardware itself, or the metal and plastic wears it is substantially less compared to even pre-2004. 20 years ago, the wear profile was pretty significant compared to the wear that we have in our plastic today. So it wears at 0.1 millimeter per year, which is very, very little, okay, especially when patients have 6 to 10 millimeters of plastic potentially in the hip and the knee, okay? So we have a number of different things that we can pull on to make sure that the surgery is planned out well, okay? And I plan out all my surgeries before I ever see a patient in the office, okay? So there's new software that allows all surgeries to be templated, planned prior to ever entering the operating theater, okay? So for me, I know when I get in there, I'm looking at, within a size exactly, how big this hip or knee should be, okay? The biggest thing to me, especially on the hip side, is that minimally invasive approaches, have been a huge evolution in terms of hip replacement, and patients able to go home safely with essentially no restrictions, afterwards, in terms of positioning and things that we used to worry about in terms of sitting down on a toilet and things like that. My patients don't have those restrictions when I do a hip replacement through the front. Okay, so when I say the front, this is called an anterior approach, or some folks will call this a direct anterior approach, which is different than a lateral approach or a posterior approach. By going through the front, I don't touch any of the muscle, okay? Like I said before, I literally push that muscle out of the way. So I'm not cutting any muscle, not violating any of that muscle. So that muscle falls right back to where it was before. So that's naturally going to result in less pain, less risk for any limping or any muscle trauma. And for me, the one of the other big benefits is I'm able to use fluoroscopy or imaging with this approach. I'm able to bring an X-ray and confirm exactly where I want my implants to sit. Okay, I'm able to easily assess the limb length for patients, where they were before to where they are now with the new implants in there. Okay, so we've seen these huge advances in patient satisfaction, and ultimately with all these checkpoints and all these things that we have now, at our disposal, for me, there's less risk for dislocation, less risk for all these other issues that, oftentimes are, talked about. Okay, so risk of joint replacement surgery. So, no matter what, there always is risk, right? So, but wear is a risk, with time. Patients that do have an elevated BMI can wear at a faster rate. Patients that, are doing high impact activity can wear at a faster rate, okay, which all makes sense. So I tell patients that, the life of any implant, okay, is multifactorial. It's their health, their weight, their activity levels. I tell patients that, it's a 1% risk every year that implant is in there, that something may be, needed for it, later on down the road, right? So, and it's cumulative. So in 20 years, there's a 20% chance that you may have to have something done for that hip or that knee joint. And oftentimes with a well-fixed implant, it can be just changing that bearing surface if it were to come down to it. But I would like to think that, my hips are hopefully going to last 30, or more years. Okay. So stages of a joint replacement, and we're going to go through these topics, and I'm going to touch on these and what that looks like for my patients in particular, and the things that I think about. Okay. So, the physician's role in hip and knee replacement, and a huge component of this is education, right? So this is why I'm doing a webinar, right? I like to talk about these things. I like to, review these things with patients about, educating them about their arthritis, what their treatment options are, okay, and improving their joint health, okay, and trying to get, them on the same page with me, okay? So I tell the patient that, a great support system and a great team, and, a great team on my side with my physical therapists and my, my office staff, and everyone being on the same page in what we're trying to achieve. That collaboration is really important to make sure that we have a successful outcome. And I think we do that really, really well at OrthoNeuro. We're all very subspecialized, so all of our patients and our staff are all on the same page. Okay. So preparation before surgery. So, like I said, education is extremely important. So I do spend a lot of time with patients to help educate them, what to expect, help alleviate some of that anxiety, of the fear of the unknown. And, some of that anxiety also is, not knowing where to go the day of surgery. So I do tell patients, and I encourage them, if you want, I'm happy to set up to have you tour the facility beforehand, so you know where to go, where to be, and what to expect. Okay. So optimization is such a big point for me in joint replacement. So, I want to make sure that patients are the absolute healthiest that they can be before they have their surgery, right? So I want to make sure that they undergo pre-admission testing where they're doing routine blood work, chest X-ray, EKG. Their blood sugar should be under control, right? If you're able to lose some weight, prior to your surgery, it can make it an easier recovery, okay, and decrease some of the risk that's associated with that. Smoking is a huge issue in terms of wound healing. So if patients are able to decrease, their smoking or stop altogether around the time of surgery, we have seen substantially less issues with wound complications. Okay. We want to make sure your blood pressure is controlled. Okay. We want to make sure that that you're not increasing, any of those risks for bleeding around the time of surgery, during surgery and post-operatively. Okay. So we want to plan and make sure that, the plan that we have and the date that, you're looking for is all, planned out, and especially around some patients' medical, issues and medications that they need to take or stop. Okay. Exercises, are important to increase strength around the hip and knee joint to make sure that we're in the best shape that we possibly can be before your surgery. Okay. And then, I touched on, the support team is extremely important, not just on my side, but, on the patient side. And if patients don't have, some of those resources, I open up that discussion with them sometimes home health, has a role to incorporate that, and bring them into their home and make sure that they're getting the care that they need. Okay. The day of surgery. So I like to talk patients through the process, right? So, I talk to patients about, when they'll arrive, how early they'll arrive, who's going to be talking with them. The anesthesia staff, will make sure that they visit with them. I will see the patient the day of surgery to make sure that, I touch on it. Any questions that, patients may have, any changes that may have occurred since I saw them in the office, okay? There's a number of different pain management options for patients that we incorporate around the time of surgery. And they're different from the hip to the knee. Generally, with a hip, I'm incorporating a short-acting spinal with a general, okay? And, normally with a knee, it's a general anesthesia, but we're also incorporating some of these blocks that we're able to numb up the lower extremity so patients are able to get up and get moving and recover quicker, and then have the opportunity to take some of those medications to control some of the discomfort they'll have as that block wears off, to make sure that it's controlled, okay? I get patients up and moving right away. So there's no downtime, with having your hip or knee replaced, right? So the whole point of having this done is to get patients up and get them moving and get them recovered so they can get back to living their life. So the faster we can get you to do that, the better the patient ultimately will be much sooner. Okay, so I talk with the family afterwards, review things with them, and make sure that we're all on the same page and communicate that. Recovery. So I talk to patients that, like I said earlier, 90% of patients, I think it's around 93%, are going home on an outpatient basis, where they're coming in the morning and going home later on that afternoon. There's obviously individual cases where patients, if you need to stay in the hospital, we could do that to monitor patients, okay? Or if medicine has a recommendation to monitor you maybe for, a day or two, okay? But support system is key. Okay, so I want to make sure that I'm on the same page with them. I do review their medications. I also provide a handout. So patients get a folder, and that folder incorporates, everything you need to do to care for your joint afterwards. And the overwhelming majority of patients are able to answer questions just by going through that packet that we give you. But we also give you a card that has my phone number in there, right? So that you're able to reach out, you're able to contact our office. We can answer any question that you may have if there's any issue or anything on an individual basis that needs to be answered, okay? And that also goes through the activity, and the physical therapists are fantastic at, going through exactly what patients need to be able to do and to recover fully, and at what pace to do that at, okay? I go over diet, as well as making sure that you're getting adequate rest, right? So I do focus on that with patients. And, that it's a huge benefit of most of these joints going home on an outpatient basis, is that they're able to sleep better, oftentimes in their own home. Okay, so for more information, speak with your primary care physician if you'd like, or if you'd like to, make an appointment, today or anytime at all. Okay, if you have somebody that you'd like to have meet with me, talk with me, I'm happy to make an appointment, or talk with them. I'm taking new patients, so you can call that phone number that I've listed here, or you can go to orthoneuro.com, and it'll kind of guide you through that process. And I'm happy to see anybody, and thank you for all attending, and I'm happy to answer your questions.
Thank you, Dr. Kolich.
Absolutely.
So we do have a few questions. The first
great.
question is, what is the chicken shot?
Yeah, so that's the hyaluronic acid injection that I was referring to. So the hyaluronic acid injection is generally something that we have to obtain approval. So it's not something, it does require a prior authorization. So normally, if a patient is interested in that, I do talk to them about what their knee joint looks like, right? Generally, we're doing these for knees. When I'm considering a candidate for something like that, like I said, it typically is mild to moderate arthritis rather than the severe realm. And once they're approved for that, generally our office will give them a phone call around 3, sometimes 4 weeks is the typical turnaround that I see. And we do that for the patients in the office. There's no restrictions. It's not something that you need to go to an ambulatory surgery center or a hospital to have completed. But generally, that so-called chicken shot or hyaluronic acid injection is something that it helps your knee joint hopefully make more lubricant for approximately a 6-month period, right? So And I do see it to where it goes both ways, to where some patients that I do these injections on, they love them and they live by them. And the other half, honestly, they come in and we do an injection like that and they say, man, that didn't make as big of a difference as I was hoping. Okay. But the overwhelming majority of those patients are patients that have more of that severe end stage, realm. Okay. Or end stage arthritis. But that's the chicken shot.
Can you cure knee arthritis?
So yeah, there's no cure for arthritis in terms of there's no way of currently regrowing cartilage. It's something that hopefully, if we catch this early, we can modify a lot of those things that, I talked about, right? So we can modify some of the activities that may be contributing to, our arthritis symptoms. And sometimes, we're able to incorporate some of these things to decrease some of the pain, discomfort, or inflammation. Okay, but there's not currently any way of regrowing any of that cartilage, but oftentimes, the most successful things of all of the things that I discussed today or tonight was that if you go through, the data, a joint replacement is the most successful thing in terms of ultimately, especially with bone and bone or end stage arthritis, it does provide substantial relief in terms of pain. Okay.
Is there a maximum weight you can be for surgery?
So that's something that's generally evaluated on an individual basis. So, for me as a joint specialist, I do see patients that, are all different shapes and sizes. And, generally speaking, optimizing patients is the most important thing. So, and that's a decision that I make with patients and where, they're currently at and, where they want to be. In some patients, if they do fall within a certain percentage. I do know the data, on certain cases, if they're up there to where the BMI may be in that morbid obesity range to where they're, 50 plus or more BMI, especially with hip replacement. Sometimes that risk does get up there to where, I talk with them. Does this make sense to do this now? Is this something that we should wait, to do later on? And I work with them. I tell every patient, I'm always happy to work with you, and I don't have a discussion about weight to hurt feelings or anything like that. It's just because I don't want to do any harm. I want to make sure that, we're safe to proceed and that patient is in the best possible health that they can be. But I have a number of patients, that do have elevated BMI that have worked very hard to try and get, to a certain number. Okay. And, sometimes we don't, get as close to that we want. And, I do a lot of joint replacements with patients with elevated BMI. So it's a difficult question to ask. And really, I evaluate that, on an individual basis. But, I have a lot of patients that, are on the upper end of, higher BMIs that still are excellent candidates for hip and knee replacements.
When do you recommend surgery? And do I have to have surgery to fix the problem?
No. So yeah. So, that's one of those big things. If you see me in the office that I talk about with patients, right? So you don't have to have surgery to fix the problem, right? So it's one of those tools in our tool belt, right? And some patients, it does come to that. But again, it's one of those things where I'm looking at, big picture, right? So I'm looking at, what does their imaging look like? And compare that to their physical exam. I compare that to their history that they're relaying to me in the office when they first come in. And I'm putting all of those things together. And what I'm trying to do is figure out, where is this patient's quality of life with the conservative treatments that they've already attempted. So normally I start from the ground up where I'm trying to, start with conservative treatments. And if those conservative treatments are no longer working, or we're doing a number of them and patients are not satisfied and they continue to develop arthritis and their quality of life continues to dip, those are the patients that I talk to about hip and knee replacement or arthroscopy potentially.
Will my hip pain go away with surgery?
So, the overwhelming majority, especially patients, if we're talking about patients with end-stage hip arthritis. So the overwhelming majority of patients that do have end-stage hip arthritis, the success rates on a hip replacement are phenomenal. So there's some of the highest numbers that we look at in terms of patient satisfaction scores. They're in the upper 90s, right? So like I was saying before, what I'm looking for is to get patients to the point to where, they have this forgotten hip that where they forget that they ever had surgery, right? So, and I think a huge component of that is to be able to do this minimally invasive and do this through the front and not cut any muscle. So if I'm not violating any of that muscle and not touching, any of that muscle, the recovery should be substantially less, right? And it shouldn't generate any pain from that area because I'm not involving that in surgery. Okay, so the overwhelming majority of patients that do have a hip replacement, that do have surgery, do very well. Now, there are some patients that may have some contributing factors from elsewhere, so that's also very possible. So some folks, unfortunately, can have what we call a two-hit phenomenon, to where they may have a hip problem, but they may also have a back problem. So if we address the hip, there may be some underlying issues that are coming from the back that may also cause some discomfort. So, and sometimes when they map out where some of the pain is distributed for hip arthritis as well as back issues, sometimes they can overlap, right? So it's our job to do a nice workup for patients to make sure that we're addressing the most problematic problem first, and that it is in fact your hip. And when it is in fact your hip, the satisfaction scores are very high.
How long can I wait if I have been told I need a replacement?
How long can you wait? So that's a good question. So, everybody's a little bit different, right? So it's not, arthritis is not all the same, right? So, in the knee, if you develop arthritis on one side of the joint versus the other side, the risks are different, right? So there's a nerve that sits on the outside of the knee. And if you develop a contracture to where the knee bends, in this kind of knock knee fashion, when we go to straighten it, there's an increased risk for what we call a foot drop. So if the patient does develop a large knock knee, okay, normally I'm trying to address that sooner rather than later because I want to decrease that risk. Now, if patients have more of a bow-legged, deformity to their knee, generally they can wait, a little bit longer as long as they're able to tolerate it. But, normally it's a quality of life issue that, I'm having this discussion with patients, and, it's not a heart, right? So I tell patients that, your hip or your knee, when we plan your surgery, it's an elective procedure, right? So when we're planning this elective procedure, we want to make sure that we're all on the same page, but we want to do this within a reasonable time to where it doesn't change, the implants that are required, or planning out your surgery through, a different fashion because there's potentially bone loss as a result of waiting too long. Okay, and I do tell patients that the longer that you wait, the more difficult it can become to recover, right? So the larger the deformity, okay, the bigger the correction that we have to make. So your muscles and your tendons do have to get used to being in that new position. So it can take longer for patients to recover if you do wait longer. And the same goes for the hip, right? So the longer you have arthritis in your hip, the tighter the muscles and tendons can become across that hip joint. So when we fix the hip, we're not touching any of those muscles. So those muscles have to get used to being in a new position as we resurface that bone and make this a successful surgery for you. Okay. So, for me, I tell patients that, you can wait as long as you'd like, but, the risks can go up the longer you wait.
What does PRP cost?
Yeah, so for me, I do have this discussion with patients, and there are a very few insurances that do pick it up. So I know I said that they don't, but the overwhelming majority will not. But we have this tiered pricing model that we rolled out recently because it makes it more approachable for patients. So, and really, it's just a difference in some of the concentration. We do offer the most concentrated dose that's on the market. So anywhere else that you go, you're going to find that there's not a more concentrated dose than we have at OrthoNeuro using the Angel system. Okay, so it varies anywhere from $500 to around $750, and some of those do change. So don't quote me exactly on that, but it's within that range to where there's 3 different tiered options, and it starts around $500.
If I have a partial knee replacement, will I need a total later?
So, that's a great question. So I should have touched on that actually. So, the patients that meet the criteria for a partial knee replacement, okay, if you're a good candidate for a partial knee replacement, 91% of patients that have a partial knee replacement never have anything else done within their lifetime. Okay, so that means 9%. So it's 9% of patients may need something else done in their lifetime. that 9%, if they were to need a, say, total knee replacement 15, 20 years down the road, okay, they would do the exact same if they had a total knee at that point. Okay, so the studies, and I've written a paper on this, that a conversion of a partial to a total, those patients still do very, very well, and you just now bought yourself potentially 20 years of a fantastic function with that knee joint, and saving and conserving bone, to where if you had to convert a total knee later on down the road, that's a much different surgery. So the patients that meet that criteria, I do have that open discussion with them, but there's a extremely high number of patients that have partial knee replacements that don't need a surgery later.
And our final question is, how long does a hip replacement last?
Yeah, so excellent question. So like I was touching on earlier, the wear profile of our implants, have come a long way to where it wears a 0.1 millimeter per year, right? So and it's a 1%, and you're getting at least 4 to 6 millimeters of plastic in a hip. So there's a lot of plastic to potentially wear into in hip joint. And again, it depends on their BMI and their activity level, and it's so multifactorial for patients in terms of wear. But when the studies that look at risk for revision, it's 1% per year, and it's cumulative, right? So in 30 years, there's a 30% chance that particular year you may need to have something done. And I don't use cement around the hip, so this is a biologic fixation that ultimately is achieved. So your own bone will grow into this implant to achieve stability. Okay, so once that happens, hopefully we should not have to touch any of the metal components if we were to go back, like I said, years down the road, and it would just be changing out potentially the ball and the plastic liner that's in there, so you have a new liner to wear into. Okay, so generally speaking, though, the easier way of thinking about it's 1% per year, and I'd like to think I'm going to see 30 years of wear on my hips.
Thank you, Dr. Kolich.
You're very welcome.
Thank you all for participating in tonight's webinar. Our final webinar of the year will be held on November 14th. Dr. Scott Stevens will speak on rotator cuff injuries. Enjoy the rest of your evening. Good night.
Thanks, everybody.